can start.
Thank you. Good afternoon, everyone. I am Dr. Isha Gupta, and I'll be presenting a case series of few rare ocular foreign body complications that we encountered at our tertiary eye care center. Foreign bodies may enter the cornea by trauma, surgery, or direct or indirect contact by rubbing of the eye. There have been multiple reports in the past of animal hair like tarantula or caterpillar hair causing conjunctivitis, chorioretinitis, or ophthalmia nodosa, but reports of human hair entering the cornea are rare. The cilium after entering the eye may remain inert or may lead to a variety of complications like iridocyclitis, inflammation, corneal decompensation, endophthalmitis, or even sympathetic ophthalmia. Similarly, bee sting injury to the eye is a rare occurrence with a sequelae ranging from mild conjunctival hyperemia to corneal decompensation and secondary glaucoma. Due to rarity of such injuries, there is no proper consensus or guidelines regarding their management. The aim of our presentation is to describe the management of few such rare foreign bodies and their sequelae that we encountered in the last 1 year. Beginning our series of cases, we present a case of retained intracameral eyelash following trauma in a 24-year-old male who presented with an injury with a plastic object in the right eye. On examination, the vision was finger counting 3 meters. On slit lamp examination, there was conjunctival congestion, seal corneal laceration of around 1 into 2 mm, and AC reaction with a 1 millimeter hypopyon. On further examination, we noticed a hair lash in the anterior chamber adherent to the anterior lens capsule, which was confirmed on AIOS2025-Hyde as a hyperreflective dot. Considering it to be an inflammatory reaction, the patient was started on oral steroids, topical steroids under antibiotic cover. In 2 weeks, there was development of leukomatous opacity at the site of laceration with the inflammatory reaction decreased. So the patient was undertaken for lash removal under local anesthesia with the help of vitreoretinal forceps. The postoperative vision of the patient was 6/6. Another case of retained intracorneal eyelash following trauma presented in a 10-year-old female. There was history of trauma with back of cleaning stick. On examination, the vision was 6/24. Slit lamp examination showed conjunctival congestion and 2 intrastromal foreign bodies that looked like hair lashes with surrounding stromal edema. AIOS2025 confirmed eye diagnosis that showed deep intrastromal hyperreflectivity. So the intrastromal lashes were removed after alcohol epithelectomy and they were sent for histopath confirmation. Postoperatively, the patient had unaided vision of 6/6 with a faint nebular corneal scar. Then cases of bee sting presented to our center. 19-year-old male presented with diminution of vision in the right eye since last 6 months. There was a definitive history of trauma with bee sting 7 months back following the diminution. On examination, the vision in affected eye was finger counting 3 meters. On further examination, there was diffuse corneal edema with epithelial bullae. AIOS2025 showed increased corneal thickness. So a diagnosis of toxic endothelitis following bee sting injury was made, and the patient was taken up for right eye endothelial keratoplasty. This is a postoperative clinical photograph in AIOS2025 at 4 months showing a clear cornea and well-centered and attached lenticule. Unaided vision of the patient was 6/60 at 6 months follow-up, improving to 6/18 with RGP contact lenses. Another case of post-bee sting corneal decompensation presented in a 21-year-old male who had history of diminution of vision in the right eye since last 6 years. There was a history of bee sting injury 7 years back. The vision at presentation was finger counting close to face. On examination, there was diffuse corneal edema with anterior polar cataract. On AIOS2025, we showed increased corneal thickness with anterior polar cataract. So a diagnosis of toxic endothelitis was made, and the patient was planned for right eye DSEC with phacoemulsification with IOL. This is the postoperative clinical photograph and AIOS2025. So intraocular cilia following penetrating injury are rare. If there is no inflammation, the patient can be kept under observation. However, in presence of inflammation or infection, surgical removal is necessary. Similarly, corneal sting by bee or wasp can lead to toxic or immunological ocular inflammation provoked by the venom compounds. Removal of the stinger is advised in acute cases. However, in cases of chronic corneal decompensation, DSEC is a viable option. So to conclude, response of eye to cilia is unpredictable, ranging from lack of reaction to severe intraocular inflammation. Decision to remove the eyelash depends upon the severity of inflammation or infection. The consequences of bee sting injury can be devastating. The need for keen observation to look for the bee sting cannot be overemphasized. Finally, if the primary pathophysiology in chronic cases is endothelial dysfunction, so lamellar procedures in the form of endothelial keratoplasty are a better option for visual recovery. Thank you.
So good presentation.
Thank you, ma'am.
So what do you do if about the cilia that is there in the anterior chamber? They migrate.
Yeah.
So one photograph you have shown that the patient has cataract, and you have gone and then dissect with phaco.
In the bee sting injury, yes, ma'am.
Yes, yes. So what have you ever seen cases where you have found you could remove the stings from inside?
In our center, till now, we haven't encountered any such case of acute cases of bee sting injury, but there have been reports that I have read of acute cases presenting with the bee sting in the cornea, which were removed.
Yes.
Yeah.
But usually they migrate inside.
Okay.
And the case that you showed with the anterior polar cataract,
Yes, ma'am.
so how did you manage? Was it already fibrosed when you did the rexes?
The anterior capsule was fibrosed, so the rexis was a bit difficult.
Yeah.
So we used a capsular rexis forceps to make the rexis.
Okay. Thank you.
Thank you, ma'am.
Now I request Dr. Shishir Agarwal sir to come.
Good afternoon, everybody. So non-healing fungal corneal ulcers effectively treated by carbolic acid cauterization. So corneal ulcers, fungal corneal ulcers, these are pretty common in North India in the agricultural belt. Like we have a center in Meerut, UP and Delhi. So we encounter history of vegetative trauma, and thereafter fungal corneal ulcers are found very commonly. We examine the patient and we conclude whether it is bacterial, fungal, viral or mixed as per diagnosis by microbiology, and clinically we give medication. Sometimes it responds, and big ulcers sometimes they don't respond, and we revisit our diagnosis and tailor the treatment accordingly. The ulcer, if it does not respond, it gets deeper, finally perforates. We see for other measures. Finally, a therapeutic PK is required. So non-responding corneal ulcers and those which are rapidly spreading. So it's a very old method of chemical cauterization by pure carbolic acid, which is very effective. We've seen, I'll just demonstrate it. So these are the bad ulcers. You've tried the antifungals, the topical and oral, and these are not responding. So you do a good chemical cauterization by pure carbolic acid. It is done under topical. You put a speculum, you take a matchstick, and that is just made pointed, and you dip it in pure carbolic acid, and this is put onto the cornea, and nothing will happen to the cornea. It penetrates a little into the corneal substance but does not penetrate deep. Betadine and other things, they actually don't penetrate at all. So the edges are removed, the undermining is removed, and so the pathogen is exposed and is killed by the carbolic, and you do a good thorough cauterization. That is the most important thing. You devote a little time, and even if it goes to the little beyond the ulcer margins, it does not matter. It will whiten a little, and then finally it will all, and it's very helpful in healing. So we've lost this thing, and it is actually very effective once the other things are not, it is not responding to the other things. So we do it very commonly, and most of the ulcers will heal, which are not healing by topical oral things. So again, the left is a very big ulcer. The other is almost perforated, a pseudocornea. You touch in the periphery in the second one. In the first one, you do a good cauterization. Just that you don't have to touch the conjunctiva, otherwise there's pain to the patient, but else you can very thoroughly cauterize. Of course, when it is perforated, just do the periphery. The acid would not go inside at any point of time. And the eyes are usually salvaged in such cases. So we are majorly talking about the fungal and maybe a secondary bacterial infection. So post-carbolic acid cauterization will give a subconjunctival chloramphenicol, and we atropine, antifungals are put, antibiotic, and we do pad and bandage, and we do this regularly for about a week or 2 weeks or 3 weeks till it heals. And it, believe me, it responds very well when it is not responding to other measures. Thank you so much.
Sir, you have shown that you are using a matchstick to
Yeah.
apply. Isn't it dangerous? I mean, you are treating an ulcer, and then you are also scraping with the
Yeah,
wooden thing.
so that is the most important thing. I mean, only if it is not, the cornea is not very thin. Otherwise, usually stroma is pretty, it's quite tense, and you thoroughly do it. That is the important thing, so that it penetrates a little deeply, and nothing actually happens. Nothing happens unless it is very thin. Only the descemetes and the endothelium is there. Most of the times, it is pretty thick, and nothing will happen actually. It will not perforate by carbolic actually. It never does.
And in cases, that one case you are showing desmetocele is there, and the periphery you are applying.
Only the periphery.
So do you use glue and BCL above, over and above?
Yeah, over that it can be done. But most of the times we'll just, I mean, that is just a rare exception that we might touch a little if it is too thick in the periphery. Otherwise, those cases are of course for therapeutic PK
Yeah.
or glue, but most of the other cases, these will be done by carbolic, and actually it works very well. Nothing happens to the cornea, it will never perforate actually.
Thank
It's a pure carbolic acid, but it never perforates actually.
Ma'am, on kar-
Pardon? It is pure carbolic, 100%.
carbolic.
Pure carbolic.
And you need to repeat it once or twice?
So no,
Only
just
once.
once, do it thoroughly. I mean, we see the difference if you don't do it very thoroughly. It tends to, the healing is delayed actually. And you do it very thoroughly, it heals so early that we've seen practically actually.
Thank you, sir.
Thank you.
Paper number 421 by Professor Bhavna Sharma. Is she here? Bhavna Sharma? Dr. Sucheta Parija? Here? Okay. What's your name? Kanika. Okay. Okay. Co-author. Right. Okay.
Good afternoon, all. I'm going to present the clinical profile of atypical mycotic keratitis in tertiary eye care center, the evolving trends. So the commonly encountered fungal species in routine practices as we see are the Aspergillus fusarium and the Candida. But infection with rare and emerging organisms should be suspected in cases of therapeutic failure or when the infection runs an unusual course. The emerging and rare fungi species includes the Schizophyllum commune, Acrimonium, Curvularia, Cladosporium, Microsporidia, and Fusarium solani. So here we present 6 cases of atypical mycotic keratitis. A 56-year-old female who presented with pain, redness, and watering for 1 month, PLPR inaccurate, with a history of vegetative matter injury, who presented with centrally located dry ulcer, 7 into 3.5 mm with endothelial plaque and 3 mm hyperpion. Microbiological investigation showed fungal hyphae on gram stain, whitish fluffy growth on culture, and it was identified as Schizophyllum commune. 2 AC washes were given with intravitreal, intracameral voriconazole, and TPK with supportive antifungal medications were given. A 30-year-old female, a 30-year-old male who presented with pain, redness, and watering for 15 days, PLPR accurate with a history of injury with husk, and presented with 8.5 into 8 mm central dry ulcer with corneal thinning. And culture was positive for Schizophyllum commune. Systemic and topical antifungals were given, followed by TPK at later date. In the third case, 57-year-old male who presented with diminution of vision, pain, redness, and watering for 15 days with a history of vegetative matter while working in farm, with a large quadrangular grey-white corneal ulcer with branching edges and dry, rough texture, with deep stromal infiltrates, and new vascularization from 11 to 1 o'clock. And microbiological investigation showed hyaline septate hyphae on KOH mount, and LPCB mount showed numerous oblong and one-cell conelia suggestive of Acremonium species. Fourth case, 14-year-old male who presented with pain, redness, and watering with a history of blunt trauma to left forehead in RTA, leading to left eye proptosis and exposure keratopathy. And on morphological examination, the ulcer was dry looking, 9 into 7 mm in size, irregular margin, brown pigmentation over the surface, involving the central cornea. On scraping on KOH mount, branched septate hyaline hyphae were seen, and on fungal culture, Curvularia species was seen. Empirical treatment for fungal keratitis was given, and USG guided supraorbital collection aspiration was performed, and after reduction of proptosis, temporary tarsorrhaphy was done to oppose the eyelids. Fifth case, 40-year-old female, pain, redness, watering, PLPR accurate, history of injury with sand particles, 7 into 7 central dry ulcer, overlying plaque and hypopine of 2.5 mm. And the fungal culture, it showed Fusarium solani. Systemic and topical antifungals were given, and glue BCL was done. Optical PK was done at later date. 30-year-old male with a history of wooden stick with 6 into 5 mm central corneal ulcer with satellite lesions and endothelial plaque with hypopines 2.5 mm. Fusarium oxysporum was isolated from the culture. Systemic and topical antifungals were effective. So the conclusion is that mean age of patients is 39 plus minus 9 years, belong to rural settings, and there was a history of ocular trauma with vegetative matter. And other attributable risk factors which were noted were diabetes and chronic steroid usage. So the schizophilum cases were refractory to medical treatment, and they progressed to corneal melt and perforation and underwent TPK. Acremonium species responded well to medical treatment. However, the ulcer progressed and evisceration was done due to non-compliance of the treatment. Curvularia cases were managed medically and underwent optical PK at a later date. In Fusarium, they responded well to medical treatment. So my take-home message is atypical fungal keratitis can be difficult to treat owing to misdiagnosis and delay in diagnosis and management. Careful history of the predisposing risk factors, onset and clinical course should be taken. Special microscopic stains and culture media should be used to isolate the organism, and treatment compliance should always be ensured. Thank you.
What all antifungal drops you started for these patients?
Ma'am, 5% netamycin that we started, ma'am, hourly during the daytime and 2 hourly during the night time. And when after 2 weeks, if the response was seen, it is the time duration is increased 2 hourly, then it is given. And
Other than netamycin, did you give any other drops?
amphotericin, ma'am,
So
0.15%.
Yes. Did you make it and
Yes,
also
when we
start for these cases which are not responding to
not
netamycin?
responding to yes,
Yeah.
ma'am.
And then how did you decide that? I mean, what was the initially we all start netamycin, and then when do you add amphotericin? This is my question. My first question was whether you add. Yes, you said amphotericin, which is
Yes, ma'am.
ideal. And then if it is not responding to, have you given AC wash also?
AC wash, yes, ma'am.
With what?
AC wash with amphotericin, ma'am.
No. With amphotericin,
Uh,
there is something else also. So the main presenting author is not there, probably.
uh,
Okay. And oral, yes, no, so you don't know. So your presenting author should be there when you are showing that you have done ultrasound guided tap. So how was it done? What was the response to that tap? Why was that done? And then you are doing tarsorrhaphy. What was the cornea? Did the patient undergo TPK with such a high orbital pressure? So what have you tapped? What was the need for the orbital tap for a corneal ulcer patient? This is what. Did the patient have endophthalmitis also? Was vitrectomy done? These are all the questions. Any idea?
No, sorry.
Okay, thank you.
Dr. Sucheta Parija, is she here? Okay. Next is Dr. Nasreen. Ma'am, please.
Presentation. Good evening, all. First of all, I thank AIOS for giving me this opportunity. This is a single case report managing a perforated fungal ulcer after pterygium surgery. A female patient aged 60 years with pterygium and immature cataract posted for pterygium excision with conjunctival autograft followed by cataract surgery as two-staged procedure. This is the pterygium. Pterygium excision with conjunctival autograft done on 27th May. On 22nd July, presented with 3 into 4 mm stromal infiltrate, 2.5 to 4 clock hours with epithelial defect and satellite lesions and 2 mm hypopyon. KOH mount revealed fungal filaments. Started on matamycin 5% eye drops hourly. Retrospective analysis of the case done and found. On seeing post-op photos and intraoperative videos, we realized that excessive corneal scraping had been done during pterygium surgery. It was done by a fellow. This is the scraping done. And patient was using steroid drops without tapering. And patient went for forming work on the third post-operative day itself. Initially showed signs of response. But in spite of complaint treatment, corneal ulcer got perforated. Corneal patch graft had been done. And patient is doing well post-operatively with topical antifungal treatment. Post-operative 1 month. Patient advised cataract surgery. After 3 months, that patch graft was doing well. And patient had to be reported for cataract surgery. Take-home messages to avoid excessive corneal scraping. Scraping should be done not so deep so as to cause corneal melting. To avoid excessive corneal scraping and excessive cautery intraoperatively during pterygium surgery. In case, frequent follow-up and avoid steroids and excessive lubrication and antibiotic coverage should be given, and judicious use of mitomycin C intraoperatively, and careful monitoring of postoperative steroid usage, patient education regarding postoperative cleanliness, and early reporting in case of pain, redness, photophobia, and defective vision. Thank you.
So, do you use mitomycin for all your patients?
No, madam. For recurrent pterygiums, we are using.
Recurrent cases. Yes. So, was it used in this patient?
No, madam.
But it is just that excessive, and don't you advise your patients to post-op? I mean, the patient went for the farming the third day.
We advise you, sir, but because this is a camp patient, came from village. She could not understand whatever the counselor has said.
But good surgery, patch graft.
Thank you. Pardon?
Cauterization was done?
No, madam.
Scleral? No.
We are not doing cauterization.
No cauterization.
Thank you.
Now I request Dr. Riddhi Khini. Please come to the dais.
Good afternoon, everyone. I am Dr. Riddhi Khaini, presenting my study on clinical outcomes and management of acute pediatric ocular surface burns, a tertiary eye care study. As we all know, ocular surface burns in its acute form is an ophthalmic emergency, and its severity depends on type of agent, exposure duration, and time of presentation. Especially in pediatric age group, it often occurs due to household chemicals, firecrackers, and accidental exposures. Our aim is to study complete epithelialization time, extent of corneal vascularization, extent of symblepharon, and visual outcomes, and also to study various interventions, emphasize importance of early intervention and preventive measures. It is a retrospective observational hospital-based study of 22 eyes of 17 pediatric patients. We included patients of age less than 14 years and having injury within 1 month, and excluded the patient having a coexisting ocular infection and extensively bodily surface burns. We analyzed their demographic details and recorded the intervention done in its immediate phase as well as in the subsequent follow-up, medical as well as surgical. We evaluated patient on torchlight as well as or slit lamp and graded as per Dua's classification. Outcome measured were complete epithelialization time on scheduled intervals, corneal vascularization extent in clock hour positions, symblepharon as per grade, and visual acuity improvement of more than 2 lines on Snellen's grade compared to on presentation. All these parameters were measured for gender, type of agent, grade of injury, and time of presentation. Results seen were age range from 1 to 11 years, male is to female ratios 8 is to 9, 5 patients showed bilateral injury, and most common agents were firecracker and tuna. Approx 50% patient presented on the same day, whereas there were 2 patients who presented even after 15 days. Mean epithelialization time was seen highest with higher grade of injury, with alkali, with patient presented late, and in females. Corneal vascularization of more than 6 grade was also seen highest with higher grade of injury, with alkali in patient presented late and in females. It is statistically also significant with grade of injury. Symblepharon formation of severe grade was also seen higher with higher grade of injury, with alkali, with late presenters, and in females, and it is also statistically significant with grade of injury. Most common interventions done were debridement and tarsography. One male patient having Lyme injury of Dua's grade 5 required tectonic lamellar patch grafting. Approx 60% patient showed visual acuity improvement, and none of the eye was lost to phthisis. We compared our study to Cat et al. And Vajpayee et al. Study. Both of these are Indian studies. We found female predominance in our study, whereas unilaterality and Lyme as an offending agent was the common finding. Firecracker was an additional offending agent in our study. Approx 54% eyes required surgical intervention in our study, where, compared to 47% in Cat et al. And 85% in Vajpayee et al. Study. Being a retrospective study, we had a very limited data. Psychological impact and economical burden was not studied here, but it can be the future provision. Severe pediatric ocular burns, especially with Lyme and firecracker, can lead to poorer outcomes, and as these injuries are more common in household settings, awareness and supervision can be the key to its prevention. Basic knowledge regarding primary management and timely referral to higher center, as well as multidisciplinary approach are essential for preserving the eye integrity, improving the cosmesis, and enhancing the overall quality of life of an affected individual. These are my references. Thank you.
For the grade 4 injury, how many patients you had?
Grade 4, ma'am, there were 4 patients.
So what did you do for those patients?
Those patients were for in immediate phase. When they came, we did the debridement, or first ocular wash was given. For then if debridement was necessary, then debridement was done under local anesthesia or general anesthesia. Then we evaluated for the Dua's grading, for their classification, and then the further management, surgical management if required, was done.
So what was done? Grade 4. You said grade 4. That is
One,
very bad.
one
Yeah.
patient required tenonplasty, ma'am.
Tenonplasty?
Yes, ma'am.
Okay. And other than tenonplasty, anything else? Was it very bad that it needed anything else? Only one. Another 3? Not sure. You are not the primary doctor. How many patients underwent amniotic membrane?
6 patients, ma'am.
Total how many were there? Total series?
Total 22 eyes of 17 patients.
Yes. In that 22, only 6 patients needed amniotic.
Yes, ma'am.
Others just
In
responded.
primary phase, 6 were done, and then after in secondary AMG was done in 4 patients.
All right.
Total 10 patients.
Thank you.
Dr. Jaita Bose.
Good afternoon. I'll be presenting a case series of microbial keratitis following collagen cross-linkage. So as we all know, CXL or collagen cross-linkage is an FDA-approved therapy to stiffen the cornea and prevent progression of corneal ectasia in patients of keratoconus, which uses riboflavin and UVA rays to increase the mechanical rigidity of the corneal stroma and halt or delay keratoconus. It can be of 3 types: standard, accelerated, or transepithelial, and I think most of us are doing the accelerated protocol these days. And also the prevalence of keratoconus in our OPD setting has been increasing, and a study which has been conducted in rural population has been shown to report the prevalence of almost 2.3% of keratoconus. The incidence of infectious keratitis after CXL can vary, and it can be as low as 0.0017% to as high as 2.4%. So in this case series, we retrospectively want to report a series of 2 patients who presented with microbial keratitis following accelerated CXL in a multispecialty eye hospital in the same week. We attempted to determine the causative organism, risk factors, if any, and the response to treatment. The first case was an 18-year-old male, and he is a known patient of congenital fibrosis of extraocular muscles. He also has keratoconus, and he underwent accelerated CXL in left eye. His BCL was removed after 3 days, and 3 days after BCL removal, he presented with this picture. And corneal scrapings revealed staph aureus. And then we did the culture sensitivity also, and he was treated with fortified cefazolin, fortified tobramycin, chloramphenicol, oral doxycycline. And after 1 week, when there were signs of resolution and scarring, we started him on loteprednol eye drops as well. He improved to 618 after 4 weeks. So we see here that the corneal scrapings has shown resistance to many of the commonly used 4th generation fluoroquinolones like levofloxacin, moxifloxacin, and in fact the lesser used drops like chloramphenicol and tobramycin have been sensitive in this patient to the organism. In the second case, it's a 15-year-old male patient who is a known case of VKC since 5 years. He had bilateral accelerated CXL performed. In the first post-op day, his BCL had dropped off, which is quite common in keratoconus patients, and it was replaced in the OPD. And after 1 week, he presented with this complaints of pain, redness, watering, and diminution of vision. He, after corneal scrapings was done, and coagulase negative staphylococcus was grown on culture, and similar sensitivity was seen in this patient also. He was given fortified drops, chloramphenicol and oral doxycycline, along with loteprednol started after 1 week. In his sensitivity also, we see that he is resistant to many of the commonly used 4th generation fluoroquinolones. And this patient also resolved gradually over a period of 4 weeks with steroids. In the review of literature, the available data indicates that bacteria are the most common organisms in post-CXL keratitis. The most common time of presentation is about 4 to 7 days after surgeries. The use of steroids and bandage contact lenses in the immediate post-operative period were associated with infection. Atopies can worsen the course of the infectious keratitis. UVA could be a trigger to reactivate latent HSV infection. In our series, both were young males. Pre-existing risk factors were present in both cases, Both of them presented with acute onset of symptoms around 7 days. Staph was isolated in both on culture, and it was resistant to the 4th generation fluoroquinolones. And both these subjects responded well to fortified antibiotics along with steroids, and they scarred at 3 to 6 weeks. In conclusion, we should be aware that VKC, blepharitis, mebomitis, conjunctivitis, canaliculitis, all these conditions may predispose patients to post-C3R keratitis. We should use preoperative and postoperative antibiotics. The CXL should be performed preferably in a OT with all sterile precautions. Alcohol debridement is advised because it can reduce the ocular microbial load. Judicious use of steroids and close monitoring till the epithelium has healed. Transepithelial may be safer as the epithelium is intact. Both eyes, simultaneous CXL, if possible, should be avoided. And microbiology guided treatment with early use of topical steroids may hasten the visual recovery. Some people see the scars and it is wounding they remember. To me, they are a proof of the fact that there is healing. Thank you very much.
A very good presentation. And you had only any other local factors like this lid margins was all ruled out before the surgery?
Yes, ma'am. As such, there was no, the patient who had this CFOEM, he had some ocular motility problems, he had ptosis. And I think the one, BCL could have been one of the factors because these patients, difficult to retain the BCL in some of these eyes. And the hygiene in case of young boys, children not that concerned about hygiene.
Yeah. So what I mean is the pre-operative lid hygiene is also
Yes,
very important.
Right.
If that has been missed, and then we cannot be blaming. Of course, the patient will have epithelial defect. BCL falling is definitely triggers. And then you are trying to replace, you have shown that it was replaced.
Ma'am, it was replaced in the OPD. So that, so it was replaced in the OPD on the first postoperative day. But obviously, OPD may have some contamination if you are replacing a BCL in the OPD.
Right.
Thank you. Thank you so much.
It's Dr. Rohit Dudeja. Not here? Dr. Bashal?
Good afternoon, everyone. Thank you, AIOS, for giving me this opportunity to speak on this topic. Today, I'll be talking about role of azathioprine in management of refractory VKC in steroid-induced glaucoma. I have no financial interest. The role of steroid comes in very severe grades in VKC, where in grade 3 or grade 4, the patients are given pulse steroid eye drops along with cyclosporine eye drops. But as we all know, steroids are having so much of complication like cataract, glaucoma, delayed wound healing, and increased risk of infection. And in this series, they have reported that rise of intraocular pressures were present in 32.9% of 249 patients, and steroid-induced glaucoma was observed in 15 patients, which was 6.1%. So coming to steroid-sparing agents, so apart from steroids, like other agents like alkylating agents, antimetabolites, T-cell inhibitors, or biological agents can be used. So I'll be talking about this azathioprine, which is an antimetabolite, and it is purine synthesis inhibitor. It incorporates into replicating DNA and halts the division of the cells. So and also it doesn't penetrate the blood-brain barrier, and it is metabolized in liver and excreted via kidneys. The side effects are nausea, fever, arthralgia. They are quite common, and bone marrow suppression, hepatotoxicity, renal toxicity, infection, and rarely it might be a carcinogenic. So in our series, we have we have 3 patients who had already had steroid-induced glaucoma. This is a 15-year-old boy with ocular allergic symptoms for 4 years. He had already undergone bilateral trabeculectomy, and still he was having this giant papillae. We can see he has glaucoma, the depressed field, visual fields, and he was already on tablet montelukast, twice steroid, and topical eye drops like anti-allergic cyclosporin, betamethasone, and carboxymethylcellulose. And in left eye, we can see he has developed shield ulcer. So, being a refractory case, we have started him on tablet azathioprine 50 mg, and oral and topical steroids were tapered gradually. And after 3 months, we can see his allergic symptoms were quite resolved, and the eye was totally quiet. He didn't have any congestion. This is another case, 14 years old boy with bilateral advanced glaucoma, underwent right eye cyclophotocoagulation, and left eye was already operated for trabeculectomy, and he was already on anti-glaucoma medications, and his symptoms were not controlled with antihistaminics and topical tacrolimus, and he was considered for systemic immunosuppression, and also azathioprine was added in this patient, and oral steroid was tapered over 6 weeks. Another case of 13 years old boy who had severe VKC with advanced glaucoma. He was already on antihistaminics, topical tacrolimus. He was initially started on oral cyclosporin, but despite his symptoms were persistent, azathioprine was added, and he was maintained after 6 months. So in our series, we had the mean age of presentation was 14 plus minus 2 years. Follow-up duration was 14 plus minus 4 months, and we had seen improvement in subjective symptoms and sign, and reduced congestion and corneal epithelial damage. No severe adverse effects were reported. 2 patients had mild gastrointestinal discomfort, for which the dose was reduced and were better. So azathioprine can be considered as a immunosuppressant in recalcitrant cases, but it should be a multi-speciality approach, and other workups like CBC, LFT, RFT, urine routine microscopy, MAN2, chest X-ray, triple H, serum IG, skin patch test should be done. So it can be considered as effective as other immunomodulators, and can be administered in conjunction with general physician or immunologist. And we should consider the risk versus benefit. In our case series, like almost all patients were blind in one eye, and we need to always monitor CBC, LFT, and RFT of such patients, and systemic side effects should be monitored. Thank you.
So good presentation. So the question is, how long this tablet to be continued?
This in this patient, the patient are usually in the teens, 14, 15 years. So it should be considered till they reach adulthood, or at least 1 to 2 years, and then slowly tapered off and then stopped.
Yeah, so the slowly tapering, you are already giving only once
We
daily.
are actually the dose we are giving is quite less. The recommended dose for azathioprine is around 3 to 5 mg per kg per day. So we are giving just 50 mg in these patients. So we are maintaining this patient. They are on like some patients are already taking it for 1 year, and once they are quiet and they are not having these symptoms recurrently, so we can stop it.
Okay. Thank you.
Thank you.
Dr. Shweta Walia, ma'am.
Good afternoon, everyone. I'll be presenting my work on ocular chemical burn, insights from a tertiary eye care center. So we all know that the ocular chemical burn is an ophthalmic emergency, and development of limbal stem cell deficiency is a serious complication of acute ocular burn, and with new promising cell therapies treatments coming, the outcome of ocular surface rehabilitative procedures has been optimistic. So the objective of our study was to study the demographic of ocular chemical burn, the clinical characteristic, the risk factors, and to study the effect of surgical outcome. So we included all the patients who presented with ocular chemical burn. These are our study tools. For acute cases, after medical management was given first, and if the patients were not healing, they were planned for surgical management depending upon the grade and type of epithelial defect. And these patients were followed bi-weekly till 3 months. So the majority of our patients were within the age group of 20 to 40 years. Males were 43, females 23. So we included 66 patients. 31.8% of the patients were illiterate. Majority of our patients were skilled workers and belonged to upper middle and upper lower category. Majority of our patients, 40, had a workplace injury, and most of these patients were aware about the protective devices that they can use, and they were also aware of the first aid devices, but still they were not using any of the protective equipments. In 59, it was accidental injury, and in 7, it was assault, and to our surprise, 4 were males. Not only the females were assaulted, 4 males were also there in our study. 9 patients were intoxicated at the time of injury, and this is one of our patient who was intoxicated, and his vomit had gone into the eye, and this is how he presented to us. In 47 patients presented within 24 hours, and 13 had bilateral injury. 26 patients had acid burns, and 45 had alkali. The majority of our patients were in the grades of 1 to 2 ocular chemical burn, and the visual acuity was in 6 to 612 in 31 patients, and 16 to 636 in 19. Now coming to complications, the elevated IOP was seen in 24, corneal opacity in 9, symblepharon in 7, entropion in 3, phthisis in 4, and pseudopterygium in 2. These are some of our pictures of the patients at the time of presentation. So 28 eyes were managed medically, 37 patients underwent amniotic membrane grafting, 7 AMG with symblepharon release, 4 underwent slit, 2 underwent keratoplasty, and 1 was eviscerated. So this is the picture of we are putting AMG. And this is the picture of doing slit procedures, and you can see that the cornea clearing after 3 months of follow-up. This is at presentation, and the last follow-up, the central cornea has begun to clear. This patient first underwent entropion surgery, and then we planned the patient for keratoplasty. So we can see that the mode of injury, reporting time, grade of injury, and visual acuity at the time of presentation was significantly associated with the final visual acuity. The AMG was done in 37 patients, and it led to early and faster reepithelialization, pain reduction, and final visual outcome, and it was done in grade 3 to 6 patients, and average duration of healing was 17 days. SLET was done in 4 patients, and we found that the corneal transparency increased, reduced the corneal vascularization, and improved the final visual acuity. Penetrating keratoplasty was done in 2 patients, and the patients who underwent SLET had significant corneal clarity at 3 months, and we are still following these patients, and we feel that there might not be need of keratoplasty in these patients. To summarize, the majority of our patients were in the age group of 20 to 40. Highest proportion of patients belong to upper lower socioeconomic class. Significant number of patients had limited education, with 37% being illiterate. Awareness and use of PPE it was present, but still they were not using it. Notably, 90% of patients were not intoxicated at time of injury. Most of the injuries were unilateral, and significant association between the initial visual acuity and the final best visual acuity and poor outcomes and initial grade of chemical injury was seen, emphasizing the need for prompt and appropriate medical intervention to mitigate the long-term complications. This study provides valuable insights into demographic characteristics, risk factors, clinical presentation, and management outcomes of ocular chemical injuries, and recent advances in surgical management has improved the final visual acuity, and these findings underscore the importance of public awareness, workplace safety measures, and timely medical interventions to improve the prognosis for individuals affected by ocular chemical burn. Thank you.
So very nice study and very elaborate presentation. You have covered most of the factors very nicely. So amniotic membrane is readily available?
We are using freshly, we are procuring it from the gynae department. We have informed them, and whenever we are planning the patient, we take planned section, and from that AMG is brought and we procure it.
So you're not using the frozen bulb?
No.
So you make sure the patient has been checked for HIV?
Yes, because since it is an elective cesarean section, so the baseline investigations and the serological markers have been done. We take only those confirmed cases. And it is, AMG has been in our institute being used since I was PG in 2004. From that time we are using it, and AMG is not a big problem in our institute.
Yeah, what about the infection part? How?
So we take it and we put it in betadine eye drops and then into gentamicin, and then we implant
How
it.
long you put it in betadine? And
5 minutes.
Thank you.
Dr. Pragya Ahuja.
Good morning, respected judges. Good morning. Good afternoon. I'll be discussing my paper is titled Overview of Pediatric Keratoplasty in Eastern India, the implications, techniques, complications, and the surgical outcomes. Pediatric keratoplasty is a challenging procedure with high rates of rejection and eventual failure. There are issues with compliance due to use of medications and the restrictions of travel. Some indications in itself have poor prognosis in such patients. These patients need repeated procedures and repeat EUAs. And finally, a very limited data is available on this topic from India. The purpose of this study was to analyze the demographics, indications, techniques, and outcomes of pediatric keratoplasty from a tertiary center in East India. A methodology, it was a retrospective study with the age group was less than 16 years. Timeline was January 2017 to March 23, and we take to all these the study outcomes were seen at 1 year. And the complications and secondary interventions that were done were during this duration of 1 year. The outcomes measured were in terms of demography, geography, the surgical indications, techniques, overall outcomes, follow-up at 1 year, the complications, and any secondary interventions that were done. So 258 keratoplasties in 245 eyes of 236 children were included in the study. The mean age was about 10 years. Significant male predominance, 1.75 to 1 was the ratio. 59% children travel more than 250 kilometers, and which became a significant factor for follow-up visits. And it also increases the cost of therapy for the child's family. The indications, the main indications, the most common was infectious keratitis, followed by keratoconus and corneal opacity. Correspondingly, the surgeries performed, most common was therapeutic PK, followed by DALC, and then optical PK being around say 19 and 17% each. The follow-up at 1 year was in 68% of patients, of which 121%, that is 69% had a clear graft, and 3.4% of these ended up thigh-sickle. The median GAs that were required for keratoplasty and follow-up, including EUAs, was about 4. Ranging up to 18 in some patients. The complications, the major ones that we saw were infection, glaucoma, and rejection. Infection included the residual infection as well as a secondary infection in the graft. This should be differentiated from the end-off, which was seen in 7.9% patients. Most common complication was graft failure, which was seen in about 25% of these patients. The secondary procedures, there were about 114 secondary procedures performed in 75 eyes, that is 30% of these eyes. And the secondary procedures most commonly done was the additional VR surgery. Then tarsorrhaphy was done. Intravitreal antimicrobials were given in about 10% of these patients. 6% of these patients ultimately required a regraft. So our indication data is different from other studies of similar socioeconomic status. We have compared a study with 3 similar studies that have been done. First in Nepal, where the most common indication was keratoconus in pediatric age group, followed by infection. Their overall graft survival rate was 78% at 1 year follow-up versus 69% in our series. And there also the major factors for graft failure were rejection, infection, and glaucoma, which is similar to our study. In a Mexican study, keratoconus was again the most common indication, followed by post-hepatic scarring, traumatic opacities, and bullous keratopathy. A similar study conducted in Iran had the most common indication was keratoconus in 58% because most allergic eye disease is seen in that area, followed by congenital opacities and regrafts. They performed PK in most of these cases, 90%, followed by DALC and DSEC. In a IRIS registry data, the analysis in which they analyzed about 544 eyes, of which 47% had complications compared to 53% in our study, and the 30% of those eyes had infection, which was 21% in our eye. The similar post-op complication rates were seen. So we realized that the most common indication in surgery is therapeutic PK. High rate of infectious indications are seen. There is high indication of DALK and ALK in patients of keratoconus, and we had a good follow-up of about 68%. Post-op complications are infection, glaucoma, and rejection, which follow the adult trends. And future plans are to have subgroup analysis and include children up to 18 years. Thank you for your kind attention.
So very good, very nice paper, and very, very much needed from the eastern part of India.
Yes.
So your common reason what other countries show is keratoconus and
Yes,
other ectatic, but yours was infection?
Infection, yes, ma'am. Most of the patients, it was a tertiary referral center for cornea, so most of our patients were of infections, including adults. So therapeutic PK was commonly performed. In our study, the second indication was keratoconus, which is lesser compared to other parts. And the keratoconus that we see, most of the patients we have done DALK, there was a difference of 1% between the percentage of keratoconus and the DALK and versus optical PK that we have done from them.
Yeah, yeah. But in India, most common cause always remains infections, injuries.
Yes, ma'am.
Yes, that is very much evident from yours. Thank you.
Yes, ma'am. Thank you.
Excuse me. Hello.
Sorry,
Yours
ma'am.
is a pediatric keratoplasty. Huh?
Yes, ma'am.
At what age in keratoconus you did keratoplasty?
Ma'am, depending on the K values, we decide when to intervene. If the pachymetry is less and the K values are very high, then we have done DALK in about 8 to 10 years of age group also.
Age only.
Yes,
With
we have.
clear graft and all?
Yes, ma'am.
Results are
We use good corneas. We set above 3,000 we take. Even if we have to strip the DM, still we keep so that the stromal thickness is good. And we used to keep our young pediatric, even full optical PKs. Whenever a young donor used to come, we used to schedule our pediatric cases at that time.
okay. Thank you.
Thank you.
Dr. Masbooba.
Good afternoon all. I am presenting on outcomes of posterior chamber phakic IOL in stable keratoconus. We all know that keratoconus is a progressive non-inflammatory corneal degeneration with stromal thinning and ectasia leading to myopic astigmatism and in advanced cases scarring. And we use phakic IOLs to correct the myopic astigmatism in stable keratoconus. There is superiority in postoperative visual performance, and it's safe and effective in the correction of moderate to high astigmatism. The skills required for insertion are similar to those in cataract surgery. The equipment needed for IOL implantation is less expensive than the excimer laser and similar to that of cataract surgery. And it is removable, therefore the refractive effect is reversible and natural accommodation is preserved, and there is lower risk of endophthalmitis and postoperative retinal detachment. We done study in June 22 to March 24. It is a prospective intervention study in patients presenting to the tertiary eye care center. Sample size is 25. Our aim is to evaluate the visual and safety outcome of posterior chamber phakic IOL in stable keratoconus after refractive error correction. And our objective is to analyze the improvement in uncorrected visual acuity, best spectacle corrected visual acuity, manifest refraction, endothelial cell count, day 1, week 1, 1 month and 6 months follow-up. Our inclusion criteria, 21 years and above, stable refraction after collagen cross-linking, less than stage 2 keratoconus, contact lens intolerant, clear central cornea with pupil size less than 6.5 mm, angle width more than 30, and exclusion criteria, progressive keratoconus, and endothelial cell count less than 1,500 millimeter square. Other eye diseases like cataract, glaucoma, retinal detachment, or retinopathy. Our methodology, we have taken the informed written consent from all the patients who fulfill the criteria, and we detail history of the patient and refraction, both all the uncorrected visual acuity, best corrected, manifest refraction and cycloplegic refraction done, and all the investigations are done, and detailed anterior segment and posterior segment examination is also done. Results, most of the people were between 26 to 30 years of age. Our cutoff was 21 years, and elder one was 33 years, and Male patients were 56%, and eye involved left eye, right eye 56%. Our objectives like uncorrected visual acuity preoperative, it was 0.96 logmar units. It improved to 0.032 logmar units in 6 months. And best corrected visual acuity, which was 0.25 logmar units pre-op, and it improved to 0.02 logmar units post-op 6 months. And sphere, which was minus 3.8, improved to minus 0.5 diopters post-op 6 months. And cylinder, which was minus 4.58, improved to minus 0.03 at 6 months follow-up. Spherical equivalent, which is minus 4.13, improved to minus 0.3. And endothelial count, it was 2,700, and it got reduced to 2,600. And the results comparing to other studies, uncorrected visual acuity of Kamia and et al. Studies was 0.9 logmar units, and best corrected was 0.15 logmar units at 6 months post-op. And Sherry, Fetch, Emira et al. For logmar, uncorrected visual acuity was 0.15 logmar units, and best corrected was 0.15 logmar units post-op 6 months. And these are our results. And from this, we can say that toric PCIOLs can be used to correct high myopic astigmatism with stable keratoconus, and uncorrected and best corrected were markedly improved after implantation. And the manifest spherical equivalent of Sherry, Fetch, Emerald et al. Was minus 0.3 post-op 6 months, and ours also was 0.03 at 6 months. And as manifest astigmatism was minus 0.6 at 6 months for Sherry, Fetch, Emerald et al. And ours also was minus 0.3 log diopters. And from this, we can say that mean manifest spherical equivalent and mean manifest astigmatism decreased significantly post-operatively. And endothelial cell count also, there was only a reduction of 200 cells per millimeter square at 6 months in all the studies. And efficacy and safety index was also good. From this, we can tell that toric ICL implantation was effective, predictable, and safe to correct refractive error and in patients with stable keratoconus. We conclude that we came to the point that implantation of phakic IOL is an effective, predictable, and safe option to correct refractive error and to improve visual acuity in patients with stable keratoconus and regular cornea. But we also compared endothelial count pre and post posterior chamber phakic IOL implantation, which was found to have positive correlation, but need further studies with longer follow-up to have a further conclusion of the safety. Thank you.
So which phakic IOLs you used?
We used Vision for toric ICLs.
Okay.
So, all the patients.
So you didn't see any other major complications?
No, because the follow-up was only 6 months. So we need longer follow-up to see any cataract formation, glaucoma, any further complications.
And was these keratoconus patients, their cross-linking and all was done for them?
Yeah, 1 year before, all the patients were done 3 years before 1 year, and we checked for progression. If there is no progression, only we taken for ICL.
Okay. So after 1 year of cross-linking, you have done ICL?
Yeah.
So the cross-linking changes, they progress up to 3 years. So you have done after 1 year?
1 year.
Thank you. Thank you.
Thank you.
Dr. Mishika Bhasin.
Wrong slides have been opened.
1226.
Good afternoon, respected judges. I am going to talk about to evaluate the conjunctival bacterial flora in patients undergoing cataract surgery. As we all know, the conjunctival sac is colonized by bacteria at birth and remains so throughout the life with changes in the flora due to various factors. The normal commensal flora can protect the host either by occupying potential colonization sites of pathogens, producing antimicrobial products, or stimulating an immune response that protects the host against infection. However, random or surgical penetrating trauma can promote the migration of resident bacterial flora into the eye, leading to endophthalmitis. Once superficial flora enters the eye during cataract surgery, several prophylactic measures are applied to suppress or limit the growth of these microorganisms, which could lead to endophthalmitis. So aim of my study is to evaluate the conjunctival flora in patients undergoing cataract surgery, and objectives are to identify the conjunctival bacterial flora in patients undergoing cataract surgery and to determine the sensitivity pattern of the conjunctival bacterial flora in patients undergoing cataract surgery. A cross-sectional study was jointly conducted in the Department of Ophthalmology and Microbiology on 60 patients undergoing cataract surgery. The type of the study is a cross-sectional study and the sample size is 60. Inclusion criteria include all the patients undergoing age-related cataract surgery in a tertiary care hospital. Exclusion criteria: patients with local inflammatory disorders like chronic conjunctivitis, dacrocystitis, blepharitis, meibomitis, patients using topical antibiotics during the last 4 weeks before conjunctival sample collection, patients on oral or topical corticosteroids or immunosuppressants, patients having previous history of ocular trauma, intra or extraocular surgery, and those wearing contact lenses, patients having uncontrolled diabetes or hypertension, patient with any other ocular or systemic abnormality, and patient undergoing cataract surgery for other than age-related causes. Standard preoperative workup was carried out, including the best corrected visual acuity, slit lamp examination, and to rule out the local ocular abnormalities, fundus examination, and blood pressure and blood sugar levels. Conjunctival sample collection was done. Microbiological analysis of the sample was done. So in my observation, the total number of the eyes, growth was positive in 49 patients, while there was no growth in 11 patients. The coagulous negative Staphylococcus was the commonest bacteria isolated in 29 eyes, followed by Staph aureus in 8 and diphtheroid in 4 cases. The susceptibility pattern of all the isolates shows 100% sensitivity to vancomycin, followed by moxifloxacin and getifloxacin. The coagulous negative Staphylococcus showed maximum sensitivity to getifloxacin, moxifloxacin, and vancomycin, and leads to neomycin. And this insensitivity pattern of Staph aureus, 100% sensitivity to moxifloxacin, getifloxacin, vancomycin, gentamicin, and then cefotaxime. So in this study, we were able to isolate bacteria in 49 eyes. In a study done by Arantes et al., the cultures were positive in 86% of eyes, while a study done by Terence et al. Showed isolation was of the order of 80%. In this study, the most frequently found organism was coagulase negative Staphylococcus aureus. This organism is related to approximately 70% of the cases of post-surgical endophthalmitis. This confirms, as with other studies, the CNS is the most common isolate in conjunctival bacterial flora worldwide. With regards to sensitivity patterns, particularly in case of CNS, moxifloxacin, getifloxacin, and vancomycin were found to be the most effective. A reduction in susceptibility rates of the older quinolones compared to the latest generation quinolones, moxifloxacin and getifloxacin was observed. The number of the CNS isolates resistant to 4 or more antibiotics was lower than 39% described by Ta et al. And 1 found by Pinna. Our results imply lower rates of ocular colonization with multiple resistant bacteria and demographic differences in the resistance pattern of the ocular flora. No fungal flora was cultured in any of the cases. Another point to be considered in that antibiotic sensitivity were performed in vitro and might not reflect the real efficiency of these antibiotics in vivo. In addition to the diffusion sensitivity test technique is based on the serum concentration of the antibiotics that might be differentiated from the concentration in the conjunctiva with the topical use of eye drops. Thank you.
So, good one. And how much resistance with Moxi was seen as compared to Getty? Was there a, yeah.
Ma'am, for Staph aureus, moxifloxacin was 100% sensitivity was there. Whereas for CNS, the moxifloxacin was resistant followed by gatifloxacin. Gatifloxacin was 100% sensitive.
Yes, because we are nowadays coming up with, even with resistance coming up to moxi also.
Yes,
That
yes,
is
ma'am.
that is the whole point.
Yes,
and
ma'am.
what organisms you have described in your flora is as per the other studies and the most predicted ones.
Yes, ma'am.
So these were normal patients. They didn't undergo any syringing before you took the swab for these patients.
No, ma'am. These patients didn't went syringing.
They had any manifest discharge, or it was just a study to see these were the patients who were undergoing cataract surgery?
Yes, ma'am.
So
these were the patients that were about to go for the cataract surgery. So we studied normal commensal flora in them only.
Right. And what is the usual antibiotic you give pre-op for your cataract surgery patients?
Ma'am, we usually give moxifloxacin only in our setup.
Right. Okay. Thank you.
Dr. Saumi Rai? Absent. Dr. Dhruv?
Good afternoon. I shall present on transforming outcomes in severe VKC, multi-layered AMT approach. To introduce to the topic, severe mixed VKC can present with Horner-Tranter dots, punctate keratitis, corneal shield ulcers, limbal stem cell deficiency, and corneal neovascularization. Particularly, shield ulcers are challenging to heal and carry a high risk of secondary infection, perforation, and significant visual disability. Their pathology arises from both mechanical trauma and toxin damage. Difficulty in managing shield ulcers has prompted the use of systemic immunomodulators like cyclosporin, tacrolimus, though these drugs pose potential local and systemic adverse effects. This case report stresses the importance of treating the advanced VKC and shield ulcers by understanding the underlying pathophysiology rather than routinely exposing young patients to systemic immunosuppressants and their associated risks. There is a case report of 16-year-old male patient referred to cornea clinic about 6 months after being unsuccessfully treated at several places with chief complaint of right eye watering and DOV since 6 months. Patient was known asthmatic on treatment 6 years with no history of any ocular trauma and or surgery. At presentation, patient had right eye vision of counting finger near face and left eye best corrected visual acuity of 6/9. On anterior segment examination, patient had giant cobblestone papilla of the right eye in UPC with large shield ulcer approximately 6 mm into 5 mm with plaque covering pupillary area with gelatinous limbus with pigmentation. Left eye had small UPC papilla with gelatinous limbus and clear cornea. Posterior segment was unremarkable in both the eyes. Patient was started on aggressive medical management. As we know, preventing the allergen exposure to the ocular surface is a key element in treatment of the VKC. Frequent cold water lavage, cold compresses over eyelids, and maintaining the proper eyelid hygiene serve as the cornerstone of the effective management. Patient was started on both eyes, cromolyn sodium 4% eye drops 4 times a day, lubricating eye drops 1 hourly as it causes frequent washout of cytokines and allergens from ocular surface. Coating the ocular surface to prevent the allergen contact as well as soothe the eye to alleviate the symptoms. Patient was also started on both eyes tacrolimus eye ointment 0.03% 3 times a day. In right eye, prednisolone acetate 1% eye drop 1 hourly only until the operative procedure was undertaken approximately after 2 weeks of the presentation of patient. Moxifloxacin eye drops to prevent secondary bacterial infection. Tablet levocetirizine 5 mg 1 tablet at night was started, and tablet montelukast was already started by pulmonologist for treatment of asthma and was continued by us. Patient was posted for right eye plaque removal with double layered amniotic membrane transplantation with fibrin glue with supratarsal injection triamcinolone. This is a post-operative day 1 photograph showing the results with prompt intervention. The upper palpebral cobblestone were resolved and cornea showed significant rarefication of opacification in pupillary area, thereby allowing marked improvement in visual acuity from counting finger near face at presentation to 6/36 unaided after 6 months. Along with frequent cold water lavage, cold compresses over eyelid, and maintenance of proper eyelid hygiene, a patient has been continued on both eyes cromolyn sodium 4% eye drops 4 times a day, carboxymethyl cellulose eye drops 6 times a day, and tacrolimus eye ointment at bedtime. Judiciously used conventional treatments lower the medication burden while preserving the limbal stem cells and preventing further severe complications. Supratarsal corticosteroid injections, surgical debridement, and amniotic barrier helps to create a favorable environment for corneal epithelial healing. Surgical debridement involves the removal of the dense plaque tissue composed of cytotoxic eosinophil granule major basic proteins from the local environment, and removal of which causes hasten the healing and reepithelialization process. Corticosteroid therapy generally relies on general suppression of local immune system and keeping it pulsed, and to minimum it prevents undesirable adverse effect. Rather than exposing the already suffering young children to the harmful and toxic effect of systemic immunosuppressive drugs, we must understand the prudent application of the fundamental understanding of disease pathophysiology. As this is a single patient case report, it would make a bigger influence to carry out a larger study for adding weightage to the subject. Thank you.
What about the glaucoma aspect? You have not spoken. You are giving prednisolone eye drops.
Yes, ma'am. Prednisolone eye drops was given only until the operative procedure was done. It was kept on pulse therapy only. Patient presented to us after was unsuccessfully treated by multiple centers. We started on cromolyn sodium. As we know, it takes approximately 2 weeks for the medication to affect.
No, I am not questioning why you have given. That is fine.
Post-operatively, the topical steroids were discontinued post-operatively. So
even with the amniotic membrane.
Low potent steroid were given. Yes,
that you should say. And when you were giving prednisolone, predfort or whatever, you were adding any anti-glaucoma medications?
No, ma'am.
To prevent, and no mention whether the IOP was very high, because already the child would have been treated and he would have come to you, no, with the.
Yes, ma'am.
So no mention about the disc changes, no mention about the IOP. We assume it was all right.
Ma'am, in the right eye there was a central plaque involving the visual axis, so fundus examination was not possible. B scan was done, which was unremarkable for cupping or anything.
Okay. Other eye was all right.
Other eye was normal, ma'am. Other anterior segment findings were there, but posterior segment the disc was normal.
So the pressure could not be measured. So you removed the plaque and you did the amniotic.
Yes, ma'am. Removal of plaque was done and double layer amniotic membrane transplantation was done along with supratarsal triamcinolone.
So for the double layered, how did you do? How the first layer was how much and the second layer was how much?
Sorry, ma'am.
So the double layer amniotic, can you just describe how did you do that double layer?
The procedure was not done by me. It was done by the consultant. I'm a resident in the.
So you don't know how much it was done. Usually they remove the plaque and then they give the small amniotic. Was it sutured or it was used fibrin glue?
Fibrin glue was used, ma'am, in the both the layers, and anchoring sutures were also taken for.
Taken at the limbus, right? That is what I wanted you to answer. Thank you.
Okay, thank you.
Yes. Yeah, please come. Yeah, that is what I wanted to ask. Please answer in the mic. That is what I wanted him to answer. Thank you.
Thank you, ma'am.
It's all right. Yes. Yes. So you are still using sodium chromoglycate? With the same drops. So maybe you can do some comparative study on the drops itself, because the newer ones are coming which are olopatadine. Wonderful. Thank you.
Thank you, ma'am. Dr. Rupashri.
Good afternoon. I am going to present on the topic evaluation of Descemet's membrane detachment based on anterior segment OCT in manual small incision cataract surgeries. No financial disclosures, ethics committee approval was obtained. DMD is an important cause of surgery-related corneal edema that may lead to corneal decompensation. When and how to intervene for DMD has been an area of controversy because the progression and the natural history are still unclear. The incidence in ECC is around 2% and 0.5 in phaco. Dua's classification of DMD goes like this, with type 1, 2, 3. In one, separation of PDL and DM, but they remain attached together. And type 2 is only DM is detached, and in type 3, PDL and DM are detached, but separated from each other. These are some images showing types of DMDs according to Dua's classification. Our aims were to evaluate DMD based on AIOS2025-Hyde in manual small incision cataract surgeries and to study the risk factors and morphology of DMD based on Dua's classification. Patients who underwent MSICS in our hospital found to have DMD during postoperative evaluation were in the source of data. They were taken from Jan 23 to December 23. It was a prospective cross-sectional study. Sample size came to be 31. The data analysis was done with different statistical methods, and p-value less than 0.05 was considered statistically significant. Patients aged 18 and above of either sex who have undergone MSICS and diagnosed to have DMD in AIOS2025 during postoperative evaluation were included in our study, and any corneal pathology and ocular comorbidities were excluded. Preoperative detailed evaluation was done with all the tests, and the grading of nucleus as per LOCS3 system and the amount of mydriasis was noted. Fundus examination and IOL calculation was done. Postoperatively also all the tests were done in detail, and AIOS2025 evaluation was done in all cases with striate keratopathy and corneal edema. Patient details were entered in the system, and DMD was classified according to Dua's classification. We divided the cornea into 4 quadrants by imaginary horizontal and vertical lines, and 2 or more quadrant involvement by DMD was considered as multi-quadrant DMD. Coming to the results, total 31 eyes of 31 patients were included. Mean age was 67 years. Among them, 80% were females, and maximum number of eyes were in the age group of 60 to 70 years. Out of 31 eyes post-op, they had uncorrected vision less than 6/60. Maximum number of eyes had mature cataracts followed by NS2, and maximum number of eyes had good pupillary dilatation of 8 mm. Types of DMD among 31, 29 eyes had type 2, type 1 and 3 were seen in each, 1 eye each. Out of 31, PCIOL was implanted in 26 eyes, and 4 were left aphakic because of intraoperative complications, and iris glove was implanted in 1 eye. Out of 31, 19 eyes had multi-quadrant DMD, and 17 had DMD involving pupillary axis. Among 29 eyes, type 2 DMD, 24 had severe corneal edema. And among 31, 28 had uncorrected vision less than 6/60. In severe corneal edema cases, the mean height of DMD was 266 and mean pachymetry value was 871. And 26 had linear detachment of DMD and 5 had DMD with tear. And these were some images of type 1, type 2 and type 3 DMDs in postoperative cases. Our statistical analysis showed there was no statistically significant difference in the following, in the correlation of multiple variables. Coming to the discussion, our study was on the evaluation of DMD based on ASOCT. There is a scarcity of data in the literature in the evaluation of DMD based on ASOCT using Dua's classification. Ours is a tertiary eye care center wherein large numbers of small incision cataract surgeries are performed. So we chose this study as the results of our study will be definitely helping in the approach towards the management. DMD, various patient-related factors which might predispose to DMD are described, which includes age over 65 years. Our study is in accordance with it. We had a female preponderance and we could not find any specific reason regarding the female preponderance in the literature. And among our patients, pupillary area was involved in 54% of the eyes. Difficult nucleus delivery in soft and harder cataracts may cause DMD. The physiological cleavage plane that exists between the anterior most adhesive zone of DM and the corneal stroma can be disrupted by mechanical forces, suggesting a weak attachment. This may be the probable cause for more number of type 2 DMDs in our case. Determining the type of DMD is very important as it influences the management, because type 1 and mixed DMDs are difficult to reattach, and type 2 is easier to reattach with air or gas tamponade compared to type 1. So to conclude, in our study, ASOCT evaluation showed maximum number of eyes had type 2 DMD followed by equal numbers in type 1 and type 3. In our study, DMD was more commonly seen in mature cataracts, older age groups, and female patients. Limitations: it was a cross-sectional study. We could not follow up the patients to know about the further management and prognosis. We could not assess if there was spontaneous reattachment. We would like to recommend ASOCT is very essential diagnostic tool in cases of post-op corneal edema to rule out DMD. What our study adds to the literature is, it's different from the other studies as it is based on the Dua's classification, which is a recent logical study, and it is based on posterior corneal anatomy. Our study has assessed occurrence of DMD in different grades of cataract, which was not included in other studies. We have also found certain preoperative association for DMD through our study, like age and types of cataract. Thank you. Thank you, sir.
What is the advantage of anterior segment OCT over other clinical methods of detection of SMS membrane detachment? What is the advantage?
Other clinical methods, yes, sir. This is a non-contact procedure, ASOCT. How we can see DMD in post-operative cases is, one is slit lamp examination, but if the striate keratopathy is grade 2 and 3, it's very difficult to see the DMD in slit lamp. So in those cases, ASOCT can be done. And one more is UBM, but ASOCT is non-contact procedure. It is definitely beneficial.
Does what type of SICS is it?
We do.
What is the size of your tunnel?
6 mm.
Okay.
5.5 to 6.
So did you see whether the nucleus was large, whether the technique, why the DMD occurred? So were there any further factors? There could have been many other factors also.
Yes. We studied. There was, as I mentioned, there was statistically significant correlation was not there, but we had many cases of mature cataracts and soft cataracts having DMD.
Okay. Thank you.
Thank you.
Nitisha, Dr. Nitisha. She's here. Dr. Pradosh, be ready. I don't see any Pradosh. Nitisha is here.
Good evening, everyone. Ophthalmomyiasis externa refers to the involvement of superficial external ocular structures, commonly by fly larvae. The clinical presentation of this parasitic ocular infection ranges from mild conjunctival irritation to more severe conditions involving the retina, which can result in permanent vision loss, highlighting the need for early diagnosis and treatment. It is usually observed in rural areas. Our patient is 60-year-old male and presented to our OPD with the complaints of severe burning, pricking sensation, watering and redness in the right eye, and patient is a shepherd by occupation. He had foreign body sensation in the right eye initially, followed by above mentioned symptoms since 2 days. This is the first right eye picture showing mild upper and lower lid edema and congestion. And visual acuity in both the eyes is 612 unaided, and it's improving to 6.9 with pinhole. And on slit lamp examination, pupils of both eyes are round, regular, reactive to light. Anterior chamber is normal in depth and quiet, and lens is transparent. As you can see, this is the right eye, where you can see a 1 to 2 mm translucent structure, motile, with a dark head. The treatment we given is, first we have we applied topical anesthesia, 0.5% proparacaine, then maggots were removed from right eye with the forceps and cotton swab, and eye wash was given with normal saline, and maggots were collected in a sterile container and was sent to the parasitology section. As these are photophobic, we couldn't remove all the worms in a single sitting, so we told the patient to close his eyes for 10 minutes and then remove the worms again. Treatment received is, after removal of worms, we have given moxifloxacin 0.5% 4 times per day for 1 week, and lubricating eye ointment CMC 0.5% 4 times per day for 1 week, and olopatadine eye drops 0.1% 2 times per day. And microscopic examination, it revealed about 1 to 2 mm length worms displaying 4 rows of spines, and at the cephalic segment had 2 large black buccal hooks. And the features were consistent with the morphological description of first larval stage of Estrus ovis larvae in the literature. Discussion: myiasis is the infestation of living or decaying tissue in the humans of animals by fly larvae. Ophthalmomyiasis specifically refers to the presence of larvae in the eye. And externa involves the infestation of external ocular structures, including the conjunctiva and cornea. And ophthalmomyiasis interna refers to the penetration of larvae into the inner structures of the eye. The female Estrus ovis retains her eggs within her body until they hatch, after which she typically deposits the larvae into the nostrils of sheep and goat. When these larvae infest the human eye, the infection is usually limited to the conjunctiva and cornea. It primarily affects shepherds and farmers in rural areas, and has also been reported in urban settings and in individuals with no direct animal contact. Other identified risk factors include pre-existing eye infections, ocular wounds, advanced age, weakened health, and poor nutrition. So the management will be prompt identification of the maggots and the removal, and topical antibiotics, antihistamines, and lubricants, and hygiene to prevent the infection. Ivermectin can be given in refractory cases and as prophylaxis. Conclusion: myiasis is the infestation rather than infection of tissues, including organs in humans or animals by fly larvae, primarily from the families of Estridae, Calliphoridae, and Sarcophagidae. These larvae are commonly referred to as maggots. The most frequently reported cause of myiasis is Estrus ovis, that is the sheep nasal board fly. Detailed history is important for management. Removal of the larvae may be difficult due to their strong attachment to the tissue, using their oral hooks and body spicules. Prompt and aggressive treatment coupled with regular follow-up care is essential for effectively managing the disease and slowing its progression. These are my references. Thank you.
So any other treatment has been reported, like some castor oil reports?
No steroids, ma'am, but
not castor oil, not steroid.
Castor oil, no, but I have seen ivermectin they have given, ma'am, but that is also 1% ivermectin solution is given just to wash the surface with povidone 6%. But other than that, nothing was there.
And what about the hygiene of the patient as such, the hands?
Yes, ma'am.
And the hair. So, they must be infestated other places also, the
yes,
nail beds, the hair of the patient. So
yes, ma'am. Hygiene should be maintained, and after they come in contact with sheep or the animals they are in contact with, they should wash their hands and all. That should be explained to the patient. And the larvae are found on the stagnant water also. Yes. So if they wash the face with that water, it will happen. So we have to instruct the patients to prevent further attacks.
So in this patient, you could remove all the larvae? Because
yes, ma'am. We have retrieved 3 larvae first, but the worms are photophobic. So under slit lamp biomicroscopy, if the light is thrown, they'll go and burrow into the corneal fornices. So we'll tell them to shut the eyes, and then again we'll see they'll come onto the surface, and we'll remove with fine forceps, non-toothed.
Interesting. Thank you.
Thank you, ma'am.
I don't think. Dr. Pradosh? Not here?
Whoever is there, we can please come to the dais for the group photograph. Who all has presented? You have to run to the other one. Photo. सर ये ले लीजिए इवेल्युएशन शीट सारा काम नहीं करना था प्लस भी करना था अरे प्लस छो अपने आप कर लेंगे प्लस किया मैम आपने मैंने नहीं किया तो बोलते जाइए आपके फोटो ले ले रहे बाद में करते हैं